Angkat aja Mbak maskernya sekali. Ya. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Welcome to our webinar series on Pediatric and Adolescent Gynecology held by Social Obstetric and Gynecology Division in collaboration with Urogynecology Division of Obstetric and Gynecology Department of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. We proudly present today our case discussion on sigmoid vaginoplasty on adolescent with vaginal agenesis. Our presenter today is Dr. Nurman Aji, and for shorten our time so that we have more time for discussion, please Dr. Nurman Aji to present the case. The time and place are yours.
Thank you so much, Dr. Shinta, for the opportunity. Good afternoon, ladies and gentlemen. Good afternoon, Professor Sonia. My name is Nurman Aji Triantoro, and I would like to deliver a presentation of case that we are going to discuss, which is sigmoid vaginoplasty in adolescent with vaginal agenesis. This patient with doctoral insights, Dr. Nuring Pangastuti, specialist obstetric gynecology consultant, which will be one of our panelists today. A 30-year-old presented with history of abdominal pain and amenorrhea with normal secondary sexual characteristic. From physical examination, his body mass index was underway with normal vital sign. At abdominal exam, uterus enlarged 2 cm below the umbilicus. Local examination revealed well-developed labia and clitoris with shallow vaginal pit. Pubic and axillary hair was present. Breast development was standard stage 3. At ultrasound, abdominal ultrasound showed enlarged uterus with distended endometrial cavity containing fluid and heterogeneously echogenic material representing blood product, suspected with hematometra. Both kidneys were present. There are no abnormality in laboratory result in this patient. And from MRI of the pelvic and inguinal region showed hematometra at hematocult was bilateral hematosalping, and the shape of the uterus is arcuate, and distal vaginal agenesis with the distance from the distal vagina to the perineum measured 3.9 cm in size. No bilateral ovarian abnormalities were seen. This is the description of the MRI with contrast. All routine examination, including colon in loop and intravenous spielography, were within normal limit. Intravenous spielography can identify renal anatomy and function. Because most of patients with vaginal agenesis, they also had anomaly at the renal organ, and colon in loop can identify the anatomy of the colon because this patient planned to sigmoid vaginoplasty procedure. Diagnostic laparoscopy revealed the uterus and left salping was enlarged. Both ovary and right tube were normal with endometriotic nodule in the pelvic wall. Diagnosis of hematometra, left hematosalping, arcuate uterus, endometriosis, total vaginal agenesis was made. Fulguration was performed on the endometric nodule, and incision is made at the vaginal introitus with ultrasound guidance. Insert dilator to the proximal vagina and insert from the vaginal introitus until it penetrates into the uterus and perform drainage. An intrauterine Foley catheter was kept in situ. This procedure was performed to drainage of the menstrual blood. Previously, we planned to vaginal pull-through procedure, but at intraoperatively, we cannot identify the vagina, and diagnosis of total vaginal agenesis was made. So we prepare for sigmoid vaginoplasty procedure. Linea mediana incision was made to the level below the umbilicus. Operation was followed with evaluation of vaginal vulva access. Gradually, increasing size of bigger dilator were introduced into the rectal vesical space, approximately diameter of 3 cm. The end of the rectal vesical space was open, so it connects with the abdominal cavity. Identification vasa vasorum at sigmoid colon and perform conduit resection by using contour, start from rectum. Then a proximal sigmoid was resected and sigmoid was anastomosed with rectum with circular stapler CDH number 29. Perineum anastomosis sigmoid was performed contraperistaltically 90 degrees clockwise, maintaining superior hemorrhoidal artery. The end of proximal sigmoid graft became vaginal canal. Uterus was incised on posterior corpus up to posterior uterine cervix, approximately 3 cm long, and the end of distal sigmoid graft was closed. Incision was made on the lateral side of sigmoid graft. Uterosigmoid was uterus side to side. Intra-abdominal drain was inserted, and one piece of povidone iodine was kept in situ on the vagina. This is illustration of sigmoid vaginoplasty in this patient. Incision of posterior corpus uterus up to posterior uterine cervix, approximately 3 cm long, and the end of distal sigmoid graft was closed. Incision was made on the lateral side of sigmoid graft, 3 cm, and uterosigmoid anastomosed side to side. This patient then received the enhanced recovery after surgery protocol for postoperative management. In this discussion, vaginal aplasia, which is listed in class V4 in the European Society of Human Reproduction and Embryology and the European Society for Gynecology endoscopic classification, usually present in adolescent as primary amenorrhea and cyclic abdominal pain related to hematometra with otherwise normal development of secondary sexual characteristic with 46XX karyotype and normal ovarian function. Vaginal atresia can present as distal or total vaginal atresia, and in the latter case, the uterus always has an anatomically normal corpus and cervical aplasia, except in sporadic patient in whom a rudimentary horn accompanies the uterus. This is classification of female genital tract anomaly according to the European Society of Human Reproduction and Embryology. This patient has U2 and with main class septa uterus and subclass with partial, and with normal septic or CO and V4 for vaginal aplasia. In this patient was classified uterus with class U2 or septa uterus because on MRI so uterus was arcuate. Ultrasound extension using the Fern approach being non-invasive, cheap, and easily available remained the initial investigation. Transabdominal scanning was effective for identifying uterine and vaginal fluid collection. Transrectal ultrasound could be considered as a diagnostic procedure of choice in the assessment of vaginal canalization defect. MRI examination could be reserved for more complex anomalies and long cervicovaginal atresia and for cases of urogenital sinus syndrome. Different diagnosis of vaginal agenesis may include myrokitensis syndrome or vaginal outlet obstruction due to a transverse vaginal septum or an incorporate hymen. In later to diagnosis, surgical excision of the relatively thin septum or hymen will be sufficient. Generally, the most common presenting symptom is primary amenorrhea. Patient may suffer from cyclic or chronic pain and pelvic or lower abdominal mass. The normally developed upper vaginal may be filled with mucus secreted from the cervix after puberty or menstrual blood after menarche. The range of treatment options include both a non-surgical and surgical approach. The various surgical methods are divided into subcategories for ease of discussion: traction method and graft-based method. An intestinal vaginoplasty can be performed using a segment of sigmoid colon, ileum, or jejunum. Harvesting the segment of bowel usually require a laparotomy. The decision of which surgical method to offer is often based on the surgeon's personal experience and preference. Sigmoid colon is preferred because it has the following advantages, such as it is self-propagating, mucus production is less of a problem than with the use of small bowel. It grows with the child when used before puberty. There's minimal risk of stenosis. It is close to the perineum. It can easily be mobilized on its vascular pedicle, and it doesn't require mold or stenting. The complication of sigmoid vaginoplasty is divided into immediate complication, which is pelvic hematoma and rectal injury, and later complication, which is shrinkage of the graft, remain the primary complication, but it can be repaired with dilator. Other complication is prolapse of the neovagina, excessive mucus production, faulties of the bowel, malignant potential, and diversion neovaginitis. Sigmoid vaginoplasty is an effective treatment for patients with vaginal atresia. Time vaginal reconstruction in this patient allow for a better quality of life and social acceptance. It also enables the patient to lead a near normal sexual life with high satisfaction rate. In this study, sexual active patients express excellent satisfaction in cosmetic and functional result of the procedure. None of patients exhibit any major complications such as graft necrosis, leakage, or severe stenosis. We believe that besides functional and aesthetical result, psychological and psychosocial recovery should also be considered to evaluate this patient and estimate their quality of life. This table shows sample post-operative instruction with focus area on activity, bathing, sexual intercourse, hygiene, vaginal discharge, and diet. He avoids strenuous activity for 6 weeks, avoid swimming or bike riding for 3 months, and resume showering following post-operative visit and patting incisional area dry. May resume sexual intercourse 3 months after surgery unless patient have been instructed otherwise. Wash hand before and after any contact with the genital area, and vaginal discharge that is brownish yellow should be expected in 4 until 6 weeks post-operatively. Begin with a liquid diet and increase usual diet as tolerated. How will vagina agenesis impact sexual life or fertility? Depending on the reproductive organ effect, sexual life and fertility could be impacted in a variety of ways. If she was born with a normal-sized uterus, she may be able to become pregnant and deliver a baby. Much of female sexual pleasure comes from sex stimulation of clitoris. Since patients with vaginal agenesis have normal external genitalia, she should be able to experience with normal orgasmic function. I think that's all from me. I would like to return stage back to Dr. Shinta as moderator for today. Thank you so much.
Okay. Thank you, Dr. Norman, for the nice presentation. And now we will come to our discussion. But first, let me introduce our two panelists, our two great panelists. First is Prof. Sonia Grover from Royal Hospital. Yeah, and second is our beloved urogynecologist expert, Dr. Nuring Pangastuti. Okay, now for first panelist, Prof. Sonia Grover, I would like to ask you first about, or I will ask about your experience in vaginoplasty, and because I know that you also perform vaginoplasty in the Children's Royal Hospital. In our department, for your information, that we have already do around 30 sigmoid vaginoplasty procedures so far, and we would like to know what is the current management for adolescent with agenesis, vaginal agenesis in Royal Hospital.
So only last week, we also had a young woman who had a MRI, which was probably quite similar. And our approach to that problem was significantly different. We had initially, she hadn't presented with the mass being quite as big as that when we first saw her. We tried to, we probably drained, may have drained it. I'm not entirely sure, but we have done a direct anastomosis. We have not done a bowel segment. We have simply pulled down and anastomosed to the perineum. So we have not needed to do major bowel surgery. And the only times when I have done or been involved with bowel segment neovaginas has been in girls post radiotherapy, when we have a completely scarred pelvis post rhabdomyosarcoma in childhood. So we would first line with a straight vaginal agenesis, we would use dilators, we would not use bowel. Occasionally we would do a shears procedure. For an anomaly such as this, we are most likely going to do a procedure which involves pulling down the upper vagina. And I must say, I'd be interested in re-looking at the MRI, because I think there's actually a bit of vagina present on that MRI, rather than stopping at cervix, or that there is some cervix clearly, and it's not a complete cervical agenesis. I would be very interested in re-looking at those MRIs, because I think we can see that there is probably some upper vagina present, and I would have done a direct anastomosis.
Okay, maybe Dr. Norman, you could show again.
Yeah, back another, yeah. It was the shape of the uterus. It was actually the other view. Oh, so can you see in the upper, we are seeing the uterus, and then we are probably seeing where it narrows, unless I'm being completely distorted, nice thick walled structure, it narrows at the internal os. And I think we're probably seeing cervix, and then the lower part may be upper vagina that's being distended. Because you can see a transition to where it becomes a bit thinner walled.
Okay,
Stop there.
Yes.
Go back just a few, because you could see again, unless I'm completely mistaken, the upper bit there is uterus, where it still remains thick walled. That's cervix, and then the lower bit is probably vagina. I'm not saying there's a lot of vagina, but I'm saying there is some vagina, and I would have pulled that vagina down to perineum.
Okay, so from the MRI, we wish to think that there is the upper vagina is present and it's distended. Okay.
Yep.
Okay, but maybe Dr. Norman, could you explain about what we found during operation?
Yes, doctor. Yes, during operation, we previously we planned to vaginal pull-through procedure, but intraoperatively we cannot identify the vagina, and diagnosis of total vaginal agenesis was made. So we prepare for sigmoid vaginoplasty procedure in this patient.
So even in the context of a partial cervical agenesis, I would have pulled that down to the perineum, as has been described by the French and the Italians. And when you pull it right down and you do an anastomosis to the perineum, you come back in 3 or 4 months' time, she will have the weight of the uterus will have created a vagina. And so I'm not saying that what you've done is wrong, but I'm just saying that there are alternative ways of tackling this problem. And I would have thus avoided having the need to do major bowel surgery. And I've also avoided the problem of the bowel segment is going to, in most people, produces quite a lot of mucus, which causes distress to people. I'm not worried about vaginal length because vaginas are stretchy places and, connected to the perineum, and a vagina will create. So I would have taken a different approach. I'm not saying that what you've done is wrong. I'm just saying that there is more than one way of achieving this. And it's interesting to be aware that there are different ways of tackling these problems.
Yes. But in this case, we have like totally agenesis vagina, but vaginal agenesis. So total is we found no vagina at all, and maybe
does not change my management. I would bring the uterus, bring the bit of cervix, bring whatever down as far as it comes down. And I would anastomose it to perineum, and you will come back in 3 or 4 months' time and there will be a vagina present.
Okay. So we will go to our next panelist, Dr. Nuring. Maybe Dr. Nuring, do you have experience with different approach for totally vaginal agenesis?
Thank you, Dr. Shinta. Good afternoon, Professor Sonia, and good afternoon, doctors, my colleague. First, I have to add the report of this patient. That's true that Dr. Norman said that first time I prepared the patient to make a pull-through vaginoplasty because of the result of MRI. I make a plan to make an incision in the rectovesical space and then pulling down the part of the proximal vagina that there are hematocolpos in this patient. But when we do the surgery, we find that when we do the rectal examination, we find that the hematocolpos so high from the vulva, and we check again with the ultrasound examination, and we find that the position of the hematocolpos and hematometra so high, more than 8 centimeters. So I try to make a dryness with a big trocar, and the result is the distance between the vulva and the hematocolpos and hematometra at that time more than 7 centimeters, about 8-9 centimeters. So I think I cannot do the vaginoplasty pull through, and at that time I only put the Foley catheter number 24F, and as a dryness from the hematometra, we put the catheter with the guiding of ultrasound at the time at the surgery, and make a plan to change the surgery to the sigmoid vaginoplasty. But unfortunately, the patient suffering from COVID-19, actually not only the patient, the doctor too. So yeah. So finally, we the 2 months from the laparoscopy and dryness vaginal procedure at that time. Actually, Professor Sonia and all of the doctors, we don't have too much experience yet in perform the sigmoid vaginoplasty surgery. Maybe since the first time we do as a team, we do the procedure in the end of 2010 until the last August 2021, we have about 30 patients. 13 of these were children or adolescent aged less than 18 years old, with the chief complaint of severe pain due to obstruction of the menstrual blood due to vaginal agenesis. In my opinion, one thing that needs attention is because some of our patients, there was 18 patients who had a history of surgery before who had a history of surgery through the abdominal or vaginal route prior to this sigmoid vaginoplasty surgery. This condition certainly increases the risk of the adhesion, especially from the abdominal route, as well as the stiff tissue becoming easier of the bleeding, increases the risk of trauma of another organ, and possibility the stenosis of the after the surgery in a history of repeated procedure in vaginal area. I think for a woman, especially in children and adolescent, the various examination procedure that are repeatedly performed on the genital can also affect the psychological condition. So I try to avoid that condition, but sometimes it's very difficult. Maybe you can give a suggestion or share your experience about the situation, so we can manage the patient more early and with more better result. Thank you, Dr. Shinta.
Thank you. Please, Prof. Sonia.
So I agree that when you are reoperating on somebody, it is always far, far, far more challenging. And I can see the circumstances which would mean that doing what you are doing with a bowel segment is maybe very much the best option. We will still get caught sometimes where somebody has operated and done something elsewhere. And it can make it challenging. We try very hard to get people to phone us, talk to us, because if we could only talk to them when the pain has only just begun and you're getting the scan results saying you have a hematocolpos or a hematometra in a 11, 12, 13-year-old, then we would much prefer to put her on the oral contraceptive pill and delay everything for some time and avoid getting to the point where you have a great big uterus full of blood and where you've got a much bigger pain problem, which is really forcing you to act. So we work hard to try and have communication pathways so that people know that we exist and so that they will speak to us and so that they will make the phone call and we can tell them, switch off her periods, let's take some time, don't operate, this could be complicated, don't race in. And we have to work hard to tell our pediatric surgical colleagues because they're also a bit prone to racing in thinking they want to fix it straight away and drain it. Whereas the moment you start draining, particularly if you're coming from the vagina and upwards, you're risking infection and sepsis and, a disaster. So trying to get the message out there to people out in peripheral places so that they switch off periods and then you've got time to quietly plan without having a mass up to the umbilicus forcing you and having to operate in a field that's already had surgery and scarred. So, but how to get the message out is always the challenge. And we still get caught with people doing what we would prefer them not to do.
Okay, so in Australia, usually you wait for until what age of the adolescent to have like definite surgery? So
if somebody like this who, she's not sexually active yet, she doesn't want to have a baby yet, if I can successfully suppress her periods, and I accept that, you know, I can have hurdles depending on the cultural background of the young person I'm dealing with, because some families think, you know, using the pill or switching off periods is bad. But if I've got somebody who is happy and agreeable, a family that is happy and agreeable, we can defer this for 5 years, 10 years. I've waited many, many years before I've done an anastomosis in some situations. And then in other situations, despite our very best efforts, you know, she's still accumulating more blood and we're clearly failing to switch her off. And then we can be forced to operate. So I have done uteroperineal assessments, anastomoses in 13-year-olds, but I'll do them, you know, I try and do them a bit later if I can suppress her in the meantime. And, you know, one of the other things that you can hope for is if you can delay it, then maybe she can dilate and make some vagina for you, and then you don't have to do as much of a distance. One other comment I would make where the uterus is such a long way away is, and it may have been difficult with such a big uterus, but to do a laparoscopy and then put a sound at the top through the fundus of the uterus, and then you're actually pushing the uterus down to meet you. Because when I'm operating to do a uteroperineal anastomosis, uterovestibulo anastomosis, you know, the uterus can be on an angle, and when you are coming at the uterus from below, you want to be getting the bottom end of the uterus, and I could be getting to the back wall of the uterus or the front wall of the uterus. So it can be useful to have laparoscopically then made a hole, put a sound through the fundus of the uterus and push down, because that way I'm getting the bottom end of the uterus being pushed down to the person who's operating at the perineum. And I can then grab it and pull it towards me and make a transverse incision. I've made H flaps on the perineum. I'm turning them inwards and I'm trying to put them inside as close to the endometrium, taking those perineal skin, hymenal skin, tucking it inwards. And you'll say, you know, that means I've got the uterus right down the bottom. Correct. But you come back in 3-4 months' time and that uterus is already 6 centimeters away. It is interesting. It's amazing.
You can make maximum mobilize the uterus down position. Yeah.
Yep.
Okay.
And sometimes, I mean, the Italians talk about having to, you know, cut the round ligaments. I have never yet had to cut the round ligaments to improve my mobilization by putting a sound through the fundus and pushing it down. I've always been able to get it from the perineal end. But that's operating in someone who hasn't got scar tissue. And so if you've got somebody who's already had, you know, previous surgery and now you've got dense scars between bladder and rectum, you know, you are in a much more difficult space to be working in. And that adds enormous risk to operating. So doing what you've done may well be the safer way to avoid those injuries to bladder and bowel.
May I ask something, Dr. Shinta, to Professor?
Yeah, of course.
Yeah.
Of course.
Yeah. Professor, do you have experience with the delayed menstrual drugs for the patient with this condition, with hematometra, when we cannot do the surgery? Yeah.
Yeah, so we will use whatever we need to use. So our starting point might be using the combined oral contraceptive pill. If they're still getting a bit of pain, we presume they are bleeding, and we would use some tranexamic acid to try and reduce the bleeding they are doing. We could use straight norethisterone, we could use Provera, we can use Zoladex, you know, GnRH analogs, but they're expensive, so I probably won't use those as my first line, but I could end up doing that if I was trying to delay. And in some of these contexts, and probably it is more with a thick transverse septum, that I might have drained the upper vagina laparoscopically. So I don't want to touch the bottom end because I don't want scar tissue, and I don't want to risk the introduction of infections or a track from, the outside world into the upper vagina. But I would be comfortable to do a laparoscopic procedure and then either reflect the bladder and drain the vagina from the front, or sometimes it's easier to go in posteriorly and go into the posterior vagina. So I'm talking about transverse septum. So I'm reducing the volume, then I can suppress and I can wait hopefully as long as possible. So we're very comfortable with delaying or trying to.
So, okay, Prof. Sonia, what is the main purpose for delaying the operation? So that maybe we could prevent the complication for the operation. What is the main goal for delaying the operation?
It's a big operation. If you're, doing a bowel segment, or I'm, if I'm doing a uterovestibular anastomosis, it's a significant operation to do in a 12 or a 13-year-old. And, she's only just coming to terms with the fact that her body is growing and changing. And to then put her through, and young teenagers and their genital areas are just, they're embarrassed. And so if I can delay all of that until she's a bit more mature, that would be my preference.
So in what age you usually operate this patient? Around 17, 18?
As I said, it's dependent on whether I can successfully suppress her. So I can think of a young woman who was born with a few other anomalies, and we had known all along that she had a vaginal atresia. And I met her when she was 10 or 11, and I put her on Provera, and I left her on Provera, and I saw her every few years, and I said, well, when are you ready? Do you want me to do anything? Have you got any pain? And she said, no, I don't want major surgery. I haven't got pain. She finished her occupational therapy studies. She took a year off and was trekking around the world with a backpack. And I must say, she came back from traveling around the world and had some back pain. And she'd gone off to the orthopedic people who had done some MRI, only to discover that she had quietly accumulated quite a lot of blood inside her uterus. And so I was doing this operation when she was 22, 23. And it was quite interesting because she had always thought that, having periods and even the potential of having babies was something that was just never going to be something for her. And when we think about the psychology of the challenges of these diagnoses, this woman, successful operations, successful anastomosis, and when I was seeing her at 4 or 6 weeks later, what she was struggling with was coming to terms with the fact that, oh my goodness, I can actually maybe have babies. I can rethink my entire life, because she'd closed all sorts of doors to, oh my God, this is going to be too difficult to do. So even there as a 22-year-old, there were things that I thought she'd just be over the moon. I didn't realize that she was having to rethink what she might be able to do in her life. And she's now 26 with a gorgeous boyfriend, and they're seriously talking about babies now. So there are lots of psychological hurdles that people have to go through. And I think the hurdles of major surgery in genital areas in young teenagers, we have to think about carefully, because it is traumatic.
Okay. Prof. Sonia, what do you have any what age of your patient, the youngest age to have this operation?
The youngest I've probably done a uterovestibular anastomosis was somebody who was about 12 or 13, and we were struggling to keep her suppressed and pain-free. And so we did the procedure.
Okay.
Now, she's a delightful young 20, I feel old. She must be about 25, 26 now. And again, with a partner and a school teacher, and wonderful. So as a teenager, she was reasonably anxious about the fact that we'd done the surgery, but she's all right now.
And no complication for the surgery? I mean, there is no shrinkage or, okay.
Nope, and she's successfully, and she's certainly one of the ones that I can say that within 4 months, you know, she had 5 or 6 centimeters of vagina, and she had none. And as I said, she's sexually active now and's got no problems at all.
So maybe in Indonesia we face different problems, different situation within Australia, because like Dr. Nuring said before, that many of the patient has already done prior surgery that maybe makes the things more complicated and difficult. Yeah, and what is your suggestion for that, for this situation? I mean, if we found that maybe the already has large hematometra, large hematocolpus, and with prior surgery, history of surgery before.
So I think, you know, and it happens with us here, that somebody says, I've just seen this problem and, you know, I think I've fixed it, or I've drained it. And I'm thinking, yes. And they've made a hole all the way through from the perineum. And so I'm going to have the discussion with that young person. If they have actually succeeded in draining the volume and she's now pain-free, then we have the choice. We can either do definitive surgery now, or we can say, you know, let's try and switch off your periods, and then we can do it when it suits you. And so we can give her the choice. Now, again, there might be factors there for you about travel and coming into Jakarta, and where do they live, and who keeps an eye on them. So I can see that there are other complexities there. But some of our patients we're also dealing with who are on the other side of Australia, and I'm going to be doing telephone consultations with them and talking to their gynecologists, you know, in Darwin, to make sure that they're managing the way that the young person wants, and they're not sure what to do hormone-wise, and I'm telling them what to do. I'm trying to buy time until she's ready.
Okay. Now I think that we will come to our Q&A, question and answer time. Please, for our residents and also doctors who join our webinar, to ask questions directly or via chat. This is very interesting case. And I think both of our panelists is ready to answer your questions. And it's really an opportunity. It's great opportunity for you all to ask questions.
While you're writing questions, I will just tell you that sometime years ago, I was giving a lecture to plastic surgeons, and they had asked me to talk to them about vaginal agenesis. And I said, we don't need you any longer to do any of the clever things you can do, and we don't want bowel segments or anything else. And it was within probably 6 months that I saw the first of my 2 girls who'd had radiotherapy, and I had to sort of go quietly to the plastic surgeons and say to them, I need your help. Because in fact, that was a situation where clearly the best option was to use a bowel segment for a neovagina in that radiotherapy field. So there will be circumstances where you need to use bowel, and it's weighing up, what are your other options? Is this your best option? And being aware what the other options are.
Mm-hmm. Okay, please. Okay, while waiting for the questions, I would like to ask, so for our general practitioner here and for our OBGYN and maybe in small cities or in other big cities, what is your suggestion? I mean, how should we do if we or what should we look for in patient with vaginal agenesis?
So just remembering that this is a young woman who's going to present with intermittent abdominal pain, and you and I know that often the young women who present with an imperforate hymen have been to the emergency department several times, and somebody has said she's constipated and, you know, sent her away, and then she eventually presents with acute urinary retention. Or so I think the message is, you know, if we're looking at a young girl who's got good breast development and got good pubic hair, who's presenting with recurrent episodes of pain, please think about obstruction. You can usually diagnose your imperforate hymen without doing an ultrasound, but if you can't see that bulging hymen, then please do an ultrasound and let's sort out where, you know, how thick the obstruction is, where the obstruction is. And then rather than leaping in, you know, the message that I try and get to people is, you know, I don't care if you take it to theatre, but if you take it to theatre and realise that you've got a long distance before you get to the hematocolpos or metra, please stop there. Please stop there and let her wake up and make the phone call to people who've got more expertise, because as you can hear, the extent of generating, you know, a more difficult operation for definitive fixing occurs if you try and help, but in fact it wasn't the right operation.
Okay, so maybe Dr. Norman himself would like to have questions for Sonia and also maybe for Dr. Nuring.
I think there are many questions from the chat box, Dr. Shinta.
Oh, okay. Okay, I think from the chat book we still have we have a comment from our staff, our senior staff, that she comment on she have a comment on your our different approach in your approach and also our approach, and she thank you for giving us new perspective. We not and yeah. Because maybe we have different situation here in Australia and also in Indonesia, in Yogyakarta. Yeah, but
Can I ask a question? Can I ask what are you doing for women with vaginal agenesis? How are you making vaginas where there isn't a uterus above, but you've just got vaginal agenesis? How are you making vaginas?
Okay, maybe Dr. Nuring could explain.
Yeah, in here in Dr. Sarjito Hospital, we do the non-surgery and surgery procedure. The non-surgery procedure we do with the Frank procedure with a vaginal dilator, like the Hagar dilator, until the number the diameter about 3 centimeters. And the surgery procedure, we do the McIndoe modification and the pull-through vaginoplasty and intestine vaginoplasty. With the McIndoe modification procedure, we open the rectovesical space and put a mold and that space about the length about 7 until 9 centimeters, and covering the mold with the fresh amnion or the graft amnion sterile, and then put the mold left about a week, and after that we continue the procedure with the dilatation, the neovagina. We find many problems in that procedure because for about until 3 months after the surgery, the patient complained about the pain when she do the dilatation. So in many cases, the patient refused to continue the dilatation, and the result is the neovagina is amended.
Shortening?
Yeah, shortening after maybe 2 months, 3 months after the procedure. For the intestine vaginoplasty, we do the procedure with the pediatric surgeon and with the digestive surgeon. We do with the colon sigmoid graft and even with the ileum graft for the neo vagina. But the most with the colon sigmoid colon graft. The reason is because the sigmoid colon is can create an excellent and aesthetic vaginal canal with a good length and can function both an access of the menstrual blood flow and for the penetrating when the patient in the future do the sexual activity. For patients, yeah.
How old are the young women when you're doing the surgery or when you're doing the Frank's procedure?
We give the patient a dilator from the locum.
Metal?
Yeah, metal dilator or rubber dilator, and but it's that is only for the women, not young women, yeah, not for adolescent. Yeah, to only to make a vaginal canal for do the sexual activity. Yeah. But if we have a patient with functional uterus, we do the make a dryness and follow with the mechanism modification or the pull-through procedure or the intestine vaginoplasty. Yeah.
Okay, thank you, Nuring. Prof. Sonia, we have questions from residents. The first question is from Dr. Elvi, our third semester of resident. She would like to ask you about the ideal time of treatment in patient with vaginal agenesis. But I think that maybe you can like give a short answer to our resident about the ideal time.
Sorry, I'm missing a word there. You want to know what we do for the management of vaginal agenesis?
No, it's about the ideal time to have to give treatment. Definitive.
Oh, the age.
Yeah.
It's entirely determined by the young woman, and if she wants to start dilating when she's 15 or 16, but most of them aren't going to start until they're 16, 17, 18, 19. So entirely up to the young woman. We don't get anyone to start dilating until they are ready and interested.
Okay, thank you. And the second question is from Dr. Anja. He asks you about the advantage and disadvantage of vaginal dilatation method for vaginoplasty.
So when we did the review a few years ago, we tried to look at outcomes as well as look at complications, and we tried to look at what everyone was doing around the world. And there's no doubt that if you're using a bowel segment neovagina, you can run into serious complications, and then there are questions about outcome, about discharge. So when we looked at all the literature that had been published on this topic, it seemed that there has been a gradual shift towards women using dilators as this first point, because first do no harm, and if they can successfully make their own vagina, then they have avoided surgery. I must say, when I started, I was taught how to do a Franks or a shears procedure, and it seemed to me that many of the women didn't feel like that they were comfortable with the surgery, that with their body. Whereas if you've made your own vagina, you've had to make friends with your body, and the women are much more comfortable to then start relationships. Whereas I had met women who had a Franks or a shears procedure done who just didn't feel comfortable with their bodies and weren't having sexual relations. So starting with dilatation seems to be a sensible way to start. And I had wondered for a long time whether or not that was as acceptable in some Asian countries. But I now am aware that my Malaysian colleagues, that is exactly what they're doing. I'm aware now that there are studies come out of Hong Kong, and the Chinese population there are doing exactly that. Now, China mainland, they've got a different operative technique, which is a bit like a Davidoff procedure, but it's called the Luo, after Professor Luo. I'm probably mispronouncing his name, I'm sorry. But a shift towards dilatation is where the trend seems to be heading. And I don't think we can use the excuse to say this cultural group, it doesn't suit. I think the fact that it's happening extensively now in Malaysia, and successfully, suggests that you can't tell me that for religious or cultural reasons it's not acceptable. But one of the critical things is peer support. And so Malaysia's got a wonderful MRKH support group. Australia's got one. Hong Kong's just had its first peer support group setting up. So peer support makes an enormous difference to young women with these sorts of anomalies.
Okay, thank you. And the next question is from Dr. Ratri, and this question is, I think it's for Dr. Nuring. She asks whether is dilatation is needed for post-operative therapy following sigmoid vaginoplasty. Do we still need dilatation?
Yeah. We do the dilatation follow the sigmoid vaginoplasty only if there are stenosis, mild stenosis in this patient, and only few patients, after the sigmoid vaginoplasty with the mild stenosis, only few patients. So not for all the procedure need the dilatation. Yeah.
And Dr. Nuring, maybe I would like to ask you: is that the patient suffered from because we know that sometimes if you use sigmoid vaginoplasty, there is mucus, excess mucus. Is the patient usually suffered from that?
The excessive mucus maybe happen in a few patients only in the few months after the procedure. About 1 until the maximum is 3 months after the procedure. But after that, it's not happened too much, the mucus. And this condition is lucky for the patient because similar with the vaginal mucus, lubricant for the vagina.
Okay, and I think this is the last question from Dr. Ingrid. She asks you, Dr. Nuring, about is it possible to use another segment of the intestinal for vaginoplasty? For example,
yeah, if you cannot find the part of the sigmoid that we can use to the graft for the neovagina. We can use the ileum or jejunum or the cecum for the graft. But why the sigmoid is the most chosen for the procedure? Because the first, the anatomically, the sigmoid colon is in the position closest to the perineum, and generally can put easily into the perineum after we mobilize the mesocolon. Yeah, and there is no need dilatation after the procedure, and the diameter of the sigmoid is similar with the vagina, and the thick of the sigmoid wall is quite enough to when the function change to the to be a vagina. So and no fragile like ileum maybe. So the chosen is the for the sigmoid is most used to the neovagina, but we can we can use the ileum or the jejunum for the procedure if we can find the part of the sigmoid.
Okay, and is the excess mucus is the complication is the same or maybe less or?
Yeah, we have one patient with complication after the surgery. This procedure is a prolapse of the neovagina, about 2 centimeters length, but the patient not complain about this condition, and she refused when I asked her to maybe if she need excision or reconstruction about the vagina. So you do nothing for that complication.
Okay. Okay, so we still have like 30 minutes left, but before we end the discussion, the webinar, maybe is there any question you can ask directly? Okay, is there any question? I would like to ask for Prof. Sonia. Have you already experienced one or your patient has already like pregnant and delivered the baby normally with cases of vaginal agenesis?
No, I don't think anyone's had a baby. I think I've got a number who are either, I've got one who's pregnant at the moment, and I've got another one who's thinking about getting pregnant at the moment. So I haven't got anyone who's delivered. Do I think they're going to deliver vaginally? No, I think they're going to have cesarean sections.
So if the patient has no cervix, is the possibility of preterm delivery is higher in these patients?
So I think we just submitted a paper actually on the whole question of that new classification from ESRA. And the idea of that new classification from ESRA was to try and improve how we classified these anomalies. And one of the problems with the new classification is it basically says, is there a cervix or is there no cervix? And the reality is that some people have some cervix and some people have a dysplastic cervix. And so I have done anastomosis to a uterus that was 4 centimetres. I have done anastomosis to uteruses that are 7 centimetres. Now, probably the uterus with 7 centimetres has got some cervix, and probably that's got a chance of pregnancy, whereas I'm not sure about the 4 centimetre one. So the new classification system is better than the AFS classification, but it's still got problems, because what you want in a classification system is a capacity to help, you know, so your cases compared to my cases, how many had babies? Well, how many of my cases had some cervix and how many had probably no cervix? I'm suspicious that your patient has some cervix And therefore, her chances of pregnancy are good. And people are certainly reporting pregnancies in women who've got a partial cervical agenesis. And so I think we're going to shift from saying cervical agenesis to cervical obstructive anomalies because there's a blockage, but some of them have got some cervix and some of them have got none. So I can't tell you that any of mine have yet had a baby. Not yet. But people around the world have certainly reported, the French have several pregnancies in their cohort.
Dr.
Sorry. Yeah. So the prognosis for women with vaginal agenesis with uterus is good actually, for have like good quality life so that she can pregnant and deliver babies.
Yep. Yes.
Okay, and that's good news. Okay, so Dr. Nuring, maybe do you have already experience with one of your patients has already pregnant with for agenesis for vaginal agenesis?
We have no patient get pregnant yet, but I hope someday. Some patient in the pregnancy program, yeah. And I hope some patient will getting a baby.
So maybe is it when we find that already had like hematosalping and also big hematosalping and also big hematometa, is it have after that she will suffer from like difficulty in to become pregnant?
Oh, I think maybe the condition of hematometra, maybe hematosalping, and the result of the any condition like endometriosis, maybe adhesion, Greek adhesion will be impact in the fertility fertility function and reproductive function of this. So like I asked before, it's very important to make earlier diagnosis and do every effort to prevent the endometriosis, prevent the any complication for the reproductive tract for the patient.
And so what is the youngest age of your patient who finally we can make a final diagnosis of vaginal agenesis?
10 years old.
10 years old. So maybe she's already have menstruation maybe once or twice and then diagnosed with, so the younger,
I hope we can find the complaint, the condition earlier as we can do, yeah. But sometimes the patient come to the other hospital, other doctor in the primary hospital, maybe. So we cannot find the patient more earlier.
Yeah. So do you have any message for our fellow OBGYN in maybe in not in big cities with expertise in urogynecologists?
Yeah, Dr. Shinta?
Do you have any message for OBGYN who maybe who live not in big cities or with urogynecologist expert?
Like Professor Sonia said before, yeah, if you find the patient with maybe amenorrhea, yeah, with a complaint of pain in the abdominal, in the pelvic, yeah, in the puberty age, maybe we must aware that possibility of the vaginal agenesis in the patient. If there are no bulging of the hymen, and when we use the ultrasound examination, maybe the distance between the vulva and the hematocolpos more than 3 centimeters, please reverse the patient. Yeah, maybe better to refer the patient because some maybe it's wise for the patient, for the future the fertility function.
And maybe Sonia, you want to add something as a message? As you said before, that we can delay or prevent the production of menstrual blood by shut down the menstrual cycle, by using contraceptive methods. Contraceptive pills.
Absolutely, but it requires people to think of this, to do the ultrasound, and to do exactly as Dr. Nuring has just said, think of it, and if it is more than 3 centimeters, please stop and speak to your colleagues who are the experienced. And you have Dr. Nuring here, who is the right person to be talking to, who can guide you so that we can do one operation rather than have to do 2 or 3 operations. And you're making Dr. Nuring's life much more complicated by having a go and it not quite working.
Yeah. Okay. Thank you. Okay. I think that we have already come to our end of webinars. So maybe I would like to make like a take-home message for our audience here. First, so that maybe it's a message for our general practitioner and also our OBGYN who live in the big city. Please, if you find any a girl with amenorrhea and pain, abdominal pain, we have to think about first maybe this is hymen infiltrata, and also maybe the more serious cause is vaginal agenesis with uterus, intact uterus, and so that you have to make if you can refer, if you are a general practitioner, then you have to refer to OBGYN, and the OBGYN also have to do ultrasound examination. And then sorry, Dr. Nuring, do you mention about 3 centimeter? What is the length of the vagina?
Obstruction. Yeah, the obstruction. Yeah.
The length of the obstruction from introitus vagina?
Yeah, until the hematocolpus.
Oh, okay. And if it is
more than 3 centimeters, please do nothing. Yeah.
And it is done by just 2D ultrasound. It works? Would it work?
I think we can do the ultrasound examination in the primary hospital. In the every OBGYN can do to do that.
Okay, and this the 3 centimeter length is can be diagnosed just by 2D ultrasound. The length of 3 centimeters.
Yeah, we can do that, and don't forget about the physical examination. Physical examination is very important. The rectal examination, and we can find the distance too.
Okay, okay, that's the first message. And the second message, that maybe we have different approach. In Australia, usually the procedure is vaginal pull through, and in Indonesia maybe we have like different approach with sigmoid vaginoplasty. But maybe because in Indonesia the case is more complicated.
Sorry, Dr. Shinta. Sorry, Dr. Shinta. Not always sigmoid vaginoplasty, but in this report, in this afternoon report, we report the sigmoid vaginoplasty.
But you also done like pull through.
As in Hindu, we do the pull through when we do the intestine vaginoplasty.
And
example in this afternoon.
Okay, and sigmoid vaginoplasty is only, and maybe it's done for special cases like maybe with or a history of operation before, something like that. Okay. Thank you for Dr. Nuring and also Prof. Sonia Grover for the nice discussion. And I think that we have like gained so much new knowledge that is very important for all of us, and especially for our residents. And maybe before we end this discussion, let's do like take photograph together, because this is Indonesian style. Before we end the webinar, we always try to take photograph together. Okay, please Dr. Nugi or Dr. Vizcara to ini conduct us for
Dr.
the.
Ada his hand, Dr. Shinta.
Oh, sorry, there is Dr. Danu, our head of department. Okay, Dr. Danu, please, maybe you can.
Yeah, Dr.
Directly.
Shinta,
Yeah.
And I just say hi to Professor Grafer. Hello, Professor. Nice to meet you again. Thank you for your discussion and enlightenment for us, which open up options for our patient management. I would like to inform you that the pediatric patient we discussed in the last meeting, the one with the children with the large cervical tumor, I had operated her, and we found that the tumor became one with the uterine, the corpus uterine. So it could not be separated. So we had to do the vaginal hysterectomy. Yeah. I sent the specimen to do the frozen section examination, and they found it malignant cell. So now we are waiting for the definitive histopathologic report. Yeah.
Okay, it's sad ending for the patient, but hopefully that we still, I think that the stage of the cancer is not advanced yet, Dr. Ardano.
Yeah. We'll inform again about the definitive histopathologic report. Okay. Thank you, Professor.
Okay. Please, Dr. Nugi, to lead our photo session.
Okay, Doctor. In 1, 2, 3. Okay, once again. In 1, 2, 3. Okay, thank you, Dr. Professor.
Okay, thank you, Prof. Sonia. Thank you very much. I hope that we can have like other case discussion later. Okay, thank you. Have a nice day. Okay, bye-bye, Prof. Sonia. And thank you for our audience in webinar. Hopefully that we can meet again in other case discussion. Okay, bye. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Nuring.
Stay safe.
Okay, stay safe.